Gives me great pleasure to introduce our second speaker, who is Professor Timothy Pawlik. He's currently professor and chair at the Department of Surgery at Ohio State University, Wexner Medical Center. His main clinical interests are in abdominal tract surgery, with special interest in hepatic, pancreatic, and biliary diseases. His first faculty appointment position was actually at the Johns Hopkins as Professor of Surgery and Oncology in 2005, and he served as Chief of Division of Surgical Oncology at Johns Hopkins until 2016. So currently, he is Professor and Chair at the Department of Surgery at Ohio State University. Professor Pollock had his undergraduate degree from Georgetown University, surgical training at the University of Michigan Hospital. He did his surgical oncology research fellowship at Massachusetts General Hospital, then went on to advanced surgical oncology training at the University of Texas, MD Anderson Cancer Center. He also has a PhD from Johns Hopkins School of Public Health in clinical investigation. He has a special interest in medical ethics and completed a medical ethics fellowship at the Harvard School of Public Health, and also has a master's in theology from Harvard Divinity School in Boston. He's extremely well published. He has more than 1,350 publications, has contributed to more than 100 book chapters, has more than 56,000 citations for his research, and has a H-index of 118. So let's hear from Professor Pawlik.
Hi, my name is Tim Pollock, and I'm the chair of the Department of Surgery and the Surgeon-in-Chief at the Ohio State University Wexner Medical Center, and I'm really happy to be joining you for the International Surgical Oncology Symposium. I wish I could be in Singapore with you in person. It's a beautiful place. So today I'm going to be talking a little bit about the importance of benchmarking and quality assurance in surgical oncology. I have no disclosures. So when thinking of benchmarking and outcomes, it was important first to kind of things into context. When we typically think of quality and we report quality in the literature, as surgeons, we've approached a siloed approach, reporting out mortality, complications, readmission. And we have not really focused on more patient-centric metrics, composite measures, and combined all these individual silos into one kind of aggregate measure of outcomes. And I would argue that doing this is a much more patient-centered approach, because patients are interested in whether they're going to have any complication, readmission, whether they're going to die from the operation. We see the episode of care as a kind of all or none phenomenon. And there's been increasing interest over the last number of years about these quality composite measures. And you can see some data from here. Papers published by Berkmeyer, who is obviously a pioneer in the field of quality and outcomes and volume outcome relationship. And then some work from our own group and some work done by the Dutch Pancreatic Group looking at composite measures of outcome. So when we're talking about composite outcome, what exactly do we mean? And this is this notion of an optimal outcome or a textbook outcome. And this could represent a whole number of different aspects of the patient's care after the operation. And typically what we think about is a textbook outcome or an optimal outcome is when a patient does not experience any of these key adverse outcomes: postoperative complications, prolonged length of stay, 90-day mortality, 90-day remission. So when a patient has a operative course that is absent any of these factors, then we would say that have a textbook outcome. And the power of this is it's really much more of a comprehensive assessment of overall quality, and it represents the kind of optimal hospital course. So as you'll see, it's interesting because while we may be able to achieve well in one of these areas, we may struggle in other areas. And it's a better way of assessing the aggregate outcomes of surgeons and of hospitals. So we've looked at this extensively and published on this extensively. And in particular, we recently published a paper looking at textbook outcomes following liver surgery for primary liver cancer, HCC, and intrahepatic cholangiocarcinoma, and assessed whether there was any change over time. And we know that, intrahepatic cholangiocarcinoma and hepatocellular carcinoma are fairly common and one of the most common indications for hepatic resection. And what we looked at in our indications were patients who had surgery, and we looked to see if there was trends in the indications for surgery and whether there were trends in outcomes over time, and in particular, textbook outcomes. So we use a large international database that had patients derived from the northern North America, Europe, as well as Asia and Australia, 15 major HPV centers, and we included only those patients who underwent curative intent surgery and had complete data on the textbook outcome parameters. And as I've noted, what we considered to be a textbook outcome was patients who had no perioperative complication with a Clavien Dino grade that was 3 or higher, did not die within 30 days of surgery, were not readmitted within 30 days of surgery, and did not have a prolonged length of stay. And we used as a benchmark less than the 75th percentile of the cohort. And in addition, when thinking of an optimal oncologic outcome, we included those patients who underwent the true margin negative resection. So this is a fairly large cohort of patients, about 1,800 patients. Roughly about half had hepatocellular carcinoma, and the other half had intrahepatic cholangiocarcinoma. What we noted was that there weren't too many trends over time with regards to tumor-specific characteristics like tumor size, lesion number, or multifocal disease. But over time, there was some sense that we were getting more aggressive in our surgical approaches. We were operating on patients who had major vascular invasion and doing more major resections. So these are the data showing the outcomes for textbook outcomes. And what you can see here to the far right is overall in the entire cohort, only 62% of patients, or about 2 out of every 3 patients, achieved an optimal or textbook outcome. And you can see with this bar graph, the different proportions of patients that achieved any one of the individual components of textbook outcome. So you can see that achieving no mortality or no readmission and an R0 reduction were significantly more common, but less common was the ability to achieve no complications and no prolonged length of stay. That being said, even those factors were still 70 to 80% when measured in isolation. But the power of these data are showing that the patients who achieved every single one of these was significantly less than the reporting out of only a single metric. So only about 60% of patients achieved all the metrics, even though each individual metric was over 60% by a fair amount. And then we looked over time at the textbook outcome rates, and there was no significant trend or improvement in textbook outcome time. And in particular, if we looked at the different components of textbook outcome, there was no real change in mortality, readmission, length of stay, or complications. So what we did find when we stratified by procedure type, not surprisingly, the portion of patients who achieved a textbook outcome after a minor resection was 70%, compared to only 50% for patients who underwent a major hepatic resection. And of note, not only did the immediate perioperative course of patients was affected by a textbook outcome, but textbook outcome also translated into different long-term survival, even after you remove the patients who experience a 30-day mortality. So there was this sense that achieving suboptimal perioperative outcomes can have important long-term outcomes relative to survival. And there's robust data on the topic of complications in the perioperative setting leading to immune compromising effects and perhaps worse oncologic outcomes in the long term. And these data would be consistent with that. So what we found from this study was that roughly only 6 in 10 patients achieved a textbook outcome. That textbook outcome really didn't decrease or change much over time, even though we were doing more extensive resections, and that using textbook outcomes as a composite measure is probably a more accurate and real world way in which we can discuss with our patients their odds of achieving a truly optimal outcome following major liver surgery. We also looked at whether certain hospital level factors might impact textbook outcome. And here in the United States, we have centers that are designated cancer centers compared to other hospitals that maybe do some cancer, but they're not designated as a center of excellence. And we wanted to look if that hospital designation actually had an impact on the rate of textbook or optimal outcomes after surgery. What we did is use a large national database of over 20,000 patients who underwent hepatopancreatic surgery. Only a small minority, about 1,700 patients, were treated at a designated cancer center. And then other subset were treated at one of our National Cancer Institute centers, which is kind of like an intermediary cancer center. And then the overwhelming majority, over 12,000, were treated in a center that had neither designated status nor NCI status. And perhaps not surprisingly, what we found was that there was a strong correlation with a patient's risk of achieving a textbook outcome based on the designation of the hospital that they were treated in. And what we found was, first of all, the overall incidence of textbook outcome on a population basis was quite low. Only just more than half achieved a true optimal outcome. And if you looked at patients who were operated at centers that did not have a designated cancer or an NCI status, their chance of achieving a textbook outcome postoperatively was only about 40%. And we can see here the different parameters within textbook outcome and notice that in a population-based study, our ability to achieve these quality metrics significantly lower than in the previous study that I shared with you that was looking at centers of excellence and not just population-based data. Again, what we found was that patients who were treated at designated cancer centers had about 30% increased odds of achieving an optimal textbook outcome after hepatic surgery, both for pancreas and liver, about 20 to 30%. And interestingly, not only were the outcomes better, but also there were differences in costs, in that patients who were treated at designated cancer centers were more likely to achieve a textbook outcome, and they had a lower cost of care, suggesting that there is a better value proposition, if you will, when patients are treated at centers of excellence, because not only can you achieve improved quality, you can also achieve lower cost and then achieve that value bonus. We also looked at there are certain factors within the hospital, like teaching hospital status, impacted outcomes relative to textbook outcome. And what we found was that the impact of a hospital being a teaching hospital had some effect, but really this was quite a modest effect with only a 4% difference between major and minor teaching hospitals. And you can see that on a multivariate analysis, this effect was present, but the odds was significantly lower at only about 10 to 17% with the impact on either pancreas resection or liver resection. That being said, the effect seemed to be slightly more pronounced when we looked at major pancreas resections versus major liver resections, and that patients who were at a major teaching hospital were more likely to have a textbook outcome, an optimal outcome, and have lower costs of care. We also wanted to look not only at perioperative care, but also this idea of textbook oncologic outcome. So how can we benchmark oncologic outcomes such as achieving a margin negative resection, an adequate lymphadenectomy, receipt of adjuvant therapy? So we looked at a large data set of patients who had pancreatic adenocarcinoma, and kind of surprisingly and disappointingly, we see that only about 20 or 1 in 5 patients had a true optimal outcome following a Whipple operation. So in other words, they had no complications, no readmission, they didn't die, And then they also had R0 resection, they had an adequate lymphadenectomy, and they got adjuvant therapy. So you can see that that's quite the piece of Swiss cheese when you're lining up all those holes, that there's only about 1 in 5 patients who can thread that needle and achieve every single component element of an ideal textbook oncologic outcome. And unfortunately, we saw over time that there really wasn't any change in the trends of achieving these different metrics at the different centers. And but what we did see was, again, perhaps not surprisingly, that at academic centers, the odds of achieving a textbook oncologic outcome was higher than if someone was treated at a non-academic medical center. So I think these data showed that only about 1 in 2 patients who underwent pancreatic surgery had a textbook oncologic outcome when you included other factors besides simple quality metrics, but also started including benchmarking of oncologic metrics into this composite analysis. And then finally, we wanted to look at patient-specific factors, right? So we talked about these and procedure-specific factors. Is it pancreas cancer? Is it liver cancer? We talked about hospital-specific factors. Is it a designated cancer center? Is it a teaching hospital? And now we wanted to look at, kind of patient-specific factors. And in particular, we wanted to look at patient race and also this notion of vulnerability. And this notion of vulnerability has to do with social determinants of health. And social determinants of health are those elements of the patient's lived environment, like transportation, economics, education, job availability, that may drive, importantly, healthcare outcomes. And in fact, what we saw was that when social vulnerability increased, and you can see here the scale goes from 0 to 100, with 100 being the most vulnerable, and the 0 being the least vulnerable, you can see that as vulnerability increase, the odds of achieving a textbook outcome decreased, and the odds or risk of serious complication increased. And this effect was present for both white patients and underrepresented minorities, but the impact of social vulnerability looked to be more pronounced amongst those patients who were non-white. And we looked at this for a number of different procedures: colon resection, lung surgery, joint surgery, and CABG, and found in looking at different geographic areas in the United States that those areas with the highest risk of social vulnerability were the least likely to achieve textbook optimal outcomes following surgery. And you can see that here in this bar graph, that looking at residential diversity and segregation, that in those areas that had very low diversity or increased segregation, that actually was an important driver of risk for complications, readmission, and the composite textbook outcome metric. And we can see here that the probability of a textbook outcome would significantly decrease as the diversity index went down, but as areas became increasingly diverse, so less residential segregation, then the probability of an optimal outcome increase. So, I think these data are important because they highlight that when we talk about textbook outcomes, quality metrics, benchmarking, that we can't simply look at disease-specific factors or hospital-level factors, but we need to also be thinking of social determinants of health and how they may impact the patient's chance from having an optimal outcome after surgery. So again, these are some of the elements of a textbook outcome that we think about. And I just want to thank once again the organizers of this meeting for the opportunity to present to you, and I look forward to the live conversation following the talk. So again, thank you very much, and I look forward to chatting with you more.
Thank you very much, Professor Pawlik, for the very interesting talk. So again, we invite people to ask questions. So we have a question from the floor. Please go ahead.
Thank you very much, Prof. Pawlik. This is Sridhar Iyer, HPB and transplant surgeon from NUH Singapore. Very thoughtful and insightful talk. The textbook outcomes is what matters to the patient really. And we are doing very badly in this area quite clearly.
Okay.
What role does MIS play in getting these textbook outcomes? And increasingly HPB and transplant surgeons HPB surgeons are looking at MIS, for example, robotic or minimally invasive surgery for laparoscopic surgery for Whipples. Two big trials showing not much difference, one showing worse outcomes. And yet, a newspaper article stating new technique is going to offer patients more hope. That's what drives the consumer behavior. How do we draw some sense out of this phenomenon? And where should we draw the line?
Yeah, thank you very much for your question. So I think you're right. Patients are definitely most interested in this concept of textbook outcomes or optimal outcomes. Because as I've said in my talk, patients experience their care kind of an all or none phenomena. And many patients at the beginning of their conversations with them about surgery, they want to know what are the chances that they're going to have an optimal outcome, so achieve all the best outcomes. And to your question about MIS, we have done some research, demonstrating that some of the components of textbook outcome, are improved with minimally invasive approaches. In particular, length of stay, and also risk of complications. Some of those data are hard to interpret because they're obviously retrospective. And typically, most of us do the more difficult cases using an open approach. And we do the more straightforward cases from a minimally invasive approach. But I think, patients more and more are asking for, minimally invasive approaches and robotic pancreaticoduodenectomies and robotic and minimally invasive liver resections. And in general, that tends to be our preferred approach when feasible at our center.
So I have a question. So I think you pointed out that in the textbook outcome, whether it is done at a designated cancer center versus a sort of a more general hospital, the outcomes are better in a designated cancer center. But how do you execute this, right? Because in all countries, there will be some sort of a turf issue because there are multiple hospitals, there are surgeons in maybe a non-designated cancer hospital who may feel that they are capable of doing that. So how do you try to improve outcome in general and then, manage this issue?
Yeah, that's a great question. So, I think there's lots of data on the volume outcome relationship after complex surgery. So we know that surgeons who do higher volume of a given procedure generally have better outcomes. I think what we're also understanding now is that even high volume centers have better outcomes, and certain centers that have certain designations, because those designations indicate that they have certain infrastructure, certain nurse to patient ratio, certain other ancillary services like, interventional radiology or transplant service, that there's hospital level structural things that improve outcomes for patients. So to your question, I think part of it is, geographic centralization of some of these cases. For more complex HPV cases in particular, I think we do need to consider centers of excellence and referral of those cases. I think that we have published data that has shown that for relatively kind of straightforward surgery, like colon surgery, let's say, that there are not dramatic outcomes among different centers, high volume versus low volume centers. But for more complex procedures like esophagectomy, pancreatectomy, and complex liver operations, I think more and more centralizing those procedures leads to better outcomes for patients.
I guess the question is, how do you execute that? So who should be the one to say, okay, hospital 1, 2, 3, you shouldn't be doing an esophageectomy or a Whipple surgery? So how do you, in your
Yeah, so I
experience?
think, so I think it's different in every country, right? So I think if you look at like the Netherlands, right, they've gone about it in a different way. They've just made decisions that certain hospitals are going to be centers of excellence, and in that country, everyone has agreed to refer those cases to those centers. I think in a place like the United States, it's very difficult because everyone wants to do the cases and all the hospitals want to keep those cases. So I think that in a place like the United States, that it will end up being the payers, the insurance companies, and the people who are paying the bills. Because when patients have complications, as I showed in my data, it is very expensive for the payers. So I think in the future, payers will dictate more and more patients can get these operations because they want value. They want good outcomes and low cost of care. And that typically is delivered at centers of excellence. So that's where I kind of see things moving forward in the future.
Okay, so we still have some time for questions. Are there any questions from the floor? If not, I will just ask one more question, because I think you actually also pointed out an important observation that patients who are more vulnerable socioeconomically also tend to have poorer outcomes. So as of a broad stroke, how do you think this problem could be addressed?
Well, I think just like we screen for medical comorbidities when we are assessing a patient's preoperative risk, I think we are beginning to understand that we also need to screen for social determinants of health when we are assessing patients in the preoperative setting, because we know that these social determinants of health can equally or even more powerfully predict their risk of prolonged length of stay, readmission, wound infection postoperatively. So by doing a screening of economic risk, residential risk, social familial risk, then ideally we can refer the patient to social services and try to put into place better support preoperatively, preemptively, so that when they do get discharged home, they will have a more robust social network to avoid some of these post-discharge challenges that they frequently face.
Okay, Jimmy has a question.
Thanks, Jimmy So from Singapore. Tim, there's an excellent talk on textbook outcome. I find that the textbook outcome is very intriguing and is a very high bar. But look at your data that most of the decline of textbook outcome is due to the post-op complications, and this is the thing that I want to discuss is as our case mix is getting more and more complex, and then in the aging populations, the patients have more comorbidities, and we are doing, as a surgical oncologist, we are doing more advanced cancers. So do you think it's really realistic to further improve the textbook outcome, as the fact that the R0 resection rates, and these are all in the top 90s, except the complication rate, but this can be driven by the case mix. So what's your take on this? Thanks.
Yeah, I think that's an excellent question. And I completely agree with you that we have had much more success decreasing the mortality associated with these operations than we have with decreasing the overall proportion of patients who have complications, even severe complications. So, I do think that we can perhaps further improve our overall risk of complications, as I mentioned, by making sure that these operations, especially complex operations, are done by high volume surgeons at high volume centers. I also think that this notion of failure to rescue is an important concept, because what our data and multiple other investigators have shown is that the overall incidence of complications may be somewhat similar amongst high and low volume centers, but high volume centers are much more able to rescue patients from complications and thereby prevent them from dying from their complications. We have also demonstrated that if you suffer a severe complication at a low volume hospital and then are transferred to a high volume hospital, you do not enjoy the entire survival benefit of a secondary admission to a high volume hospital. In other words, the transfer after a severe complication may be too late. So again, emphasizing that these cases should be primarily performed at high volume hospitals that have the expertise, not only by the surgeons, but also by the nursing, the staff, and the infrastructure in that institution.
Okay, thank you. So we have a last question from the audience. So the question is, what about effort to educate patients or people to be armed with proper information that patients may be easily influenced by media advertisements such as robotic surgery? And that he thinks that to improve the outcome, it would be transparency of sharing the data, although it might be difficult. So what's your comment on that?
Yeah, I think that's a great question, and it's the exact reason why I feel strongly about textbook outcome, because when we share with patients that there's only a 1% or 2% risk of mortality, and then we say, well, maybe there's a 10 to 20% risk of complications and there's only a 5% risk of readmission, that's very difficult for a patient to understand the overall composite risk of all those things stacked together. So by using composite measures like textbook outcome, we can have kind of a more transparent conversation that the chance that you're going to have no problems whatsoever is probably, only about like 60%. 40% of patients have some issue. And it's a more honest and transparent conversation with those patients about their overall experience and overall episode of care to talk about these composite measures. And I also think that as surgeons, we tend to focus on a lot of technical issues, but I also think it's very important to talk about overall prognostic issues with patients when they're undergoing surgery, so that we can have good alignment of therapeutic expectations between the surgeon and the patient. Because we have done multiple studies showing that very commonly there is not therapeutic alignment with regards to goals of care. And this is something that needs to be addressed.
Okay, thank you very much. Are there any more questions? Okay, go ahead, please, from the floor.
Hi, good evening, Prof. Pollock. Glenn Bonney, I'm one of the HPB and transplant surgeons. Thank you for that amazing talk. I'm a big fan and a scholar of your work for many years. My question really is textbook outcome a sort of unidimensional way of looking at it, when actually potentially there are other dimensions that perhaps affects different healthcare systems differently, like cost? And you've alluded to a biological measure of, I think I saw lymph node harvest at your pancreatic resection work. And do you think it should be perhaps a bit more three-dimensional, involving cost as well as textbook outcome, including outcomes in biology and survival as well? And is this work you're doing, you're already looking at, etc.? Thank you.
Thank you for that great question. So yes, I completely agree with you that we need to add additional dimensions to this concept. And as you point out, some of that is value, which relates to cost. And the other thing that I would point out is that the notion of textbook outcome I presented today tends to be very physician-centric. I mean, these are things that we as surgeons traditionally have highlighted as important quality metrics, and they are. But some of the work we are now doing is around patient-reported outcomes and having focus groups with patients to see what they value and what they think should be put into these composite measures. The other thing that is important is that not all these things are equally weighted. So as I presented it today, a textbook outcome maybe has 5 or 6 things. But we would all agree that dying from the operation should probably have a much heavier weight than an extra day or 2 in the hospital, right? So I think as we go forward with these composite measures, we need to have more patient input, and we have to be more sophisticated in weighting the different outcomes relative to their value in the patient's eyes and in the patient's experience.
Thank you. So I don't see any more questions online, and I think no more questions. So really thank you very much for the great discussion. And so we will close this plenary session, and thank you again to our 2 excellent speakers, both from the United States. Thank you.